Good morning, class. Today, we delve into the critical, often unseen functions of public health during disasters, specifically focusing on the threats of epidemics and pandemics. Public health acts as the invisible shield, protecting populations when crises hit. We will explore everything from core public health roles and strategic planning to specialized surveillance systems and logistics. By the end of this session, you will understand how public health seamlessly integrates cutting-edge science, robust logistics, and deep community engagement to transform chaos into a structured response. Public health management during a disaster is a multifaceted, holistic endeavor that extends far beyond the hospital room. It's a system designed to manage risk at the population level. Holistic integration. It combines environmental health, sanitation, water safety, data-driven decision-making, epidemiology, and crisis communication, risk messaging. Core focus areas. Prevention. Stopping illness before it starts, often through vaccination campaigns, mask distribution, or hygiene promotion. System functionality. Ensuring the entire healthcare infrastructure, from clinics to supply chains, remains operational and flexible, known as surge capacity. Behavioral health support. Addressing the mental and emotional fallout to mitigate long-term stress, anxiety, and trauma in affected communities. Example: during the 2009 H1N1 pandemic, while clinicians treated flu cases, public health departments were simultaneously establishing points of dispensing, or PODs, for mass vaccination, developing public school closure guidelines, and tracking the virus's genomic shifts, all to protect the broader community. Public health teams fulfill 5 essential and interconnected roles during a disaster. Investigate and analyze. Epidemiology. Rapidly establishing the outbreak scale, transmission patterns, reproductive number, RO or RT, and identifying the most vulnerable demographic groups. Identify and screen. Case management. Implementing prompt case identification, isolation for the sick, and quarantine for those exposed. This breaks the chains of transmission. Behavioral health support. Resilience building. Providing psychological first aid and counseling to responders and affected populations to stabilize immediate distress and mental health challenges. Health promotion and risk communication. Disseminating accurate, actionable, and culturally relevant information via mass communication channels to build trust and guide behavior. Resource management and logistics. Ensuring the Strategic National Stockpile, SNS, is deployed effectively and critical supplies, PPE, ventilators, testing kits, reach the point of need. Historical events serve as crucial, often painful lessons in preparedness. The flaw of top-down responses. Centralized planning often fails if it ignores local capacities, cultural context, and resource limitations. Response must be flexible and locally adaptable. Clarity of roles. Ambiguity between national, regional, and local public health authorities leads to delayed action and redundancy. Supply chain resilience. Critical supplies must be domestically sourced or held in reserve, immune to geopolitical disruption. Proactive communication. The vacuum of information is instantly filled with misinformation and disinformation. Trust must be built before a crisis. Equitable service delivery. Disasters disproportionately affect the marginalized. Response plans must include active strategies to ensure equitable access to testing, vaccines, and care for vulnerable populations. Example: during the 2014-2016 Ebola outbreak in West Africa, it was initially hampered by a lack of trust in Western health measures. Success came only when public health teams partnered directly with community elders and religious leaders to implement safe burial practices and contact tracing, demonstrating the power of localization. Facing a pathogen like a novel zoonotic virus means operating in an environment of extreme uncertainty. Rapid epidemiological assessment. The immediate priority is determining the mode of transmission, aerosol, droplet, vector, the incubation period, and the approximate fatality rate before widespread community transmission occurs. Communication under uncertainty. Health officials must communicate what they know, what they don't know, and what they are doing to find out. This transparent approach maintains credibility and manages public expectation. Managing human factors. Public health messaging must account for and actively mitigate common responses like denial, fear, panic, and xenophobia. Example: when the first cases of SARS, severe acute respiratory syndrome, in 2003 emerged, the initial rapid global spread was contained primarily by quick implementation of travel restrictions and aggressive isolation protocols, driven by immediate, though imperfect, epidemiological data. Public health strategies are dictated by the pathogen's core characteristics. Factor. Definition. Ease of spread, for example, high RO. Strategic impact. Dictates the need for widespread NPIs like mask mandates and capacity limits. Virulence. Severity of illness or fatality rate. Determines the required level of hospital surge capacity, ICU beds, ventilators, the intensity of therapeutics. Case definition. Standardized criteria for confirmed cases. Ensures uniform data collection across jurisdictions, allowing for accurate mapping of the outbreak. Communication. Clear public guidance on prevention. Directly influences public adherence to mitigation measures. Pandemics represent the apex of public health crisis, characterized by simultaneous, widespread strain on all sectors of society. Health system overload. Clinical capacity is often quickly exceeded, leading to ethical challenges regarding resource allocation, for example, triage protocols. Disproportionate impact. Vulnerable populations, elderly, low-income, refugees, immunocompromised, face greater risk due to pre-existing health disparities and limited access to care. Coordination with non-traditional partners. Public health cannot act alone. It requires coordination with logistics specialists to set up mass testing or vaccination sites, engineers and utilities to ensure power, water, and sanitation systems remain functional, infrastructure planners to maintain critical supply chains. The intrinsic properties of the pathogen determine the required speed and severity of the intervention. Fast-moving, high-virulence viruses, e.g. early SARS-CoV-2, demand rapid, strict, and scalable interventions like early lockdowns, aggressive contact tracing, and immediate travel bans to buy time for vaccine development. Slow-moving, low-virulence viruses, e.g. seasonal H1N1 influenza, allow for more measured responses focused primarily on increasing clinical care capacity, targeted vaccination, and protecting specific high-risk groups. Effective disaster planning is a continuous cycle, not a one-time document. It rests on three critical pillars. Legal and ethical frameworks. The legal authority for drastic measures like mandatory quarantine, isolation, or business closures must be pre-approved, understood, and ethically justified before the crisis hits. Resource management, or pre-positioning. A detailed, dynamic inventory of critical resources, PPE, ventilators, therapeutic drugs, hospital bed capacity, and a plan for their rapid and secure distribution. Training and drills, or exercising the plan. Regular, realistic scenario-based drills improve operational speed, refine decision-making processes, and highlight previously unseen gaps in the plan. Mitigation strategies are non-medical actions designed to slow the spread of the disease and protect the vulnerable. Non-pharmaceutical interventions, or NPIs. These are population-level actions like physical or social distancing, mandatory mask usage, business closures, and school dismissal. They are crucial for flattening the epidemic curve. Sustaining essential services. While society slows down, essential services, water purification, power generation, food supply chains, waste disposal, must remain fully operational to prevent secondary public health crises. Community engagement and adherence. Mitigation only works if the public complies. Working with local faith leaders, nonprofits, and community activists ensures that directives are trusted and followed. Example: in early 2020, South Korea successfully used massive-scale anonymous digital contact tracing, a key NPI, to isolate cases quickly and avoided a full-scale national lockdown. Testing is the essential diagnostic engine that drives the public health response. Deployment, utilizing mobile testing units and drive-through sites, maximizes community accessibility, especially for populations with limited transportation. Prioritization, testing protocols must be established to prioritize high-risk groups, symptomatic health workers, individuals in congregate settings, to control outbreaks quickly. Personnel safety, ensuring all staff involved in collection and testing are protected by appropriate PPE and rigorous infection control protocols, is non-negotiable to maintain workforce capacity. Infection control is the practical application of epidemiological knowledge. Source control and isolation, rapidly identifying the source of infection, the index case, and ensuring they are quickly and safely isolated to prevent further transmission. Standardized protocols, maintaining stringent protocols for hand hygiene, proper medical waste management, and environmental disinfection in all settings, hospitals, schools, workplaces. Public education, the why, explaining the scientific reason behind hand hygiene and respiratory etiquette, increases public understanding and compliance. Public health has a mandate to protect those most at risk, as disasters expose and exacerbate existing social inequities. High-risk groups, this includes the homeless, migrants, incarcerated individuals, residents of long-term care facilities, and those with chronic illnesses. Challenges: these groups often face limited access to health information, lack of reliable transportation for testing or vaccination, and culturally inappropriate outreach materials. Solutions: response must involve culturally and linguistically appropriate materials, establishing dedicated outreach sites, example mobile clinics in underserved neighborhoods, and strong partnerships with local nonprofit organizations. Effective public communication is the most critical tool for managing fear and ensuring public action. It must be a deliberate strategic function, not an afterthought. Clear and consistent. All agencies, local health, state government, federal bodies, must speak with a unified voice. Conflicting messages erode trust. Trusted source. Messages must be delivered by credible subject matter experts, example the chief medical officer, state epidemiologist, or highly trusted community leaders. Actionable, communications must provide clear, practical steps. Here is what you need to do now. Avoid merely offering updates or abstract statistics. Accessible, utilize multiple platforms, TV, social media, print, radio, and ensure availability in multiple languages and accessible formats, example, Braille or sign language interpretation. Public health disaster response also incorporates preparedness for intentional biological threats. This requires a heightened level of coordination, rapid detection and attribution, using surveillance to quickly identify an unusual cluster of illness and linking it to a potential biological agent. Decontamination and infection control, immediate implementation of protocols for mass cleaning and disinfection to neutralize the agent and prevent secondary infections. Heightened surveillance, activating systems designed to track specific, unusual disease patterns, syndromes, that might indicate the deliberate release of a Category A agent. The nature of the release dictates the speed and visibility of the response. Overt release. The event is immediate and obvious. Example, the 2001 anthrax letters. The presence of the agent was known immediately, triggering a law enforcement and public health response focused on prophylaxis and environmental cleanup. Covert release. The release is hidden, and the first sign is an unusual pattern of illness. Example, a contaminated food or water source. Example, deliberate contamination of a city reservoir. This requires syndromic surveillance to notice the spike in ER visits for a specific symptom, example, unexplained gastroenteritis, and subsequent detailed epidemiological investigation to trace the source. Biological agents are categorized by their risk and potential for impact. Category A. Highest priority, can be easily disseminated or transmitted, result in high mortality, and cause panic, example, smallpox, anthrax, botulism. They require maximum preparedness. Categories B and C. Moderate impact agents, example, salmonella, emerging pathogens like Nipah virus. These require enhanced disease surveillance and diagnostic capacity. Response focus, preparedness for these agents is about diagnostics, rapid identification, therapeutics, stockpiled drugs or vaccines, and robust communication plans to manage public fear. Effective disaster response demands a highly structured and integrated operational framework. Unified command. All responding agencies, public health, emergency management, fire, police, must operate under a single shared incident action plan to avoid duplicated effort and conflicting orders. Interagency collaboration, seamless coordination is required across all sectors, military, civilian, private sector. Federal frameworks utilize established national systems. Strategic National Stockpile, SNS, the National Repository of Antibiotics, Vaccines, Chemical Antidotes, and other life-saving medical supplies. Surveillance is the process of collecting, analyzing, and interpreting health data to detect and prevent outbreaks. Syndromic surveillance, tracking nonspecific health indicators like spikes in over-the-counter medication sales, school absenteeism, or emergency room chief complaints like respiratory illness to detect an outbreak before lab results confirm it. Epidemiological investigation, the shoelather, identifying cases, defining the geographical scope of the threat, and using detailed patient interviews and data mapping to trace the transmission routes. Mental health monitoring, tracking patterns of stress, anxiety, and burnout among both the public and first responders, which are often the hidden casualties of a disaster. The ability to scale medical services quickly is key to resilience. Hospital preparedness and surge capacity, plans for converting non-clinical spaces into patient care areas, example, tents, field hospitals, protecting healthcare staff from infection, and securing critical supplies, oxygen, PPE, mass medical care, developing standardized protocols for rapidly screening and treating large numbers of people outside of traditional hospital settings. The LRN is a critical integrated system for rapid and secure identification of high-threat pathogens. Structured network, a tiered system of federal, state, and local laboratories working under standardized protocols. Rapid identification, it provides the capability to quickly rule out common agents and identify rare or deliberately introduced high-risk agents. Policy support, the real-time data provided by the LRN informs crucial national policy decisions, clinical guidance, and the deployment of countermeasures. Public health management during disasters is the essential bridge between pure science and population protection. It is an integration of epidemiology, logistics, risk communication, and clinical care. The 4 essential C's. Success hinges on coordination, communication, capacity, and community-based action. The goal, effective disaster management, ensures not only the immediate survival of the population, but also the long-term resilience of the community and its essential services.